Good evening, everyone. Just want to make sure everyone has a chance to join the session this evening, so I'll give it another minute. I hope you all have something nice to drink or eat and settle in for the next hour for this very exciting presentation. Okay, I think we'll get started. So for those of you who haven't been to any of our webinars before, who haven't met me, my name is Wendy Walrabenstein and I'm a nutritionist and communications lead at Plant-Based Health Professionals UK. And it gives me great pleasure to announce our final webinar before we have a summer break, which is with Wendy Walrabenstein and Carlijn Wagenaar. And they are both researchers at Reed. Wendy is also a registered dietitian, and Carlijn is doing her PhD as well as being a doctor. So this trial, Plants for Joints, is something I think many of our audience have heard about, but this is what today's session is going to talk all about. We're going to hear all about their multidisciplinary lifestyle program using plant-based nutrition to help with rheumatic disease and osteoarthritis. So this is what today's session will focus on, and we're going to have Wendy and Carlijn come back for a live Q&A at the end. And they're going to be saving some of their findings for VegMed London 2023, which is Plant-Based Health Professionals UK's flagship conference, co-organised with PAN and sponsored by ProVeg International. And this is Europe's largest medical conference on plant-based nutrition. It has been running in previous years. This is the first time it's back in London since 2019. And tickets are selling fast, so do get your early bird ticket, which has now been extended until the end of this month, until 30th of June. It's going to be an information-packed weekend, sort of one-stop shop to get all your questions, all your burning questions answered on plant-based nutrition. And I'm really excited. The program lineup is available on the website, so you can go and check that out. And if you are coming along to VegMed, then let us know in the chat, and also let us know what you do, your name, where you're joining from, as I imagine we've got an audience from around the place today. These webinars would not be possible without veganfitness.com, who kindly lend us their Zoom platform, and CPD and CME accreditation from ACLM and BSLM. And you will receive a copy of the slides and the certificate in your inbox in a few days' time. Recordings of the webinars are available for PBHP members only and go up on the site in a few days' time. Plant-Based Health Professionals UK, or PBHP UK, is a community interest group dedicated to promoting the health benefits of a sustainable and healthy whole food plant-based diet. And we have so many different resources on our website for you to go and check out. Lots of free fact sheets, a free 21-day health challenge, videos, articles, and more. The best way to support our work is to consider joining us as a member. This is open to everyone around the world, with student memberships starting from as little as £15, I think, per year. And you can visit pbhp.uk to subscribe to our free weekly newsletter, donate via pbhp.uk/donate, and follow us on Facebook, Instagram, and Twitter. So now I'm going to hand over to Wendy, who's going to be kickstarting this evening's presentation, and then we'll go over to Carlijn a little bit later. And at any point, if you've got questions for both of them, please do use the Q&A function at the bottom of the screen, because that helps me when it comes to Q&A. See you in a bit, and best of luck, Wendy.
Yes, thank you so much, Roini, for this great introduction. Let me see if I can share my screen. Let's see. There it is. Yeah. So welcome everybody, and welcome to this webinar. It feels a bit like a general repetition for VegMed, because we will definitely be there also live, of course. And today we will share with you some of the results of our Plants for Joints project. Not all the results. If you want to know what the results were in our one-year extension study, you definitely have to come over to London. We will be there too. Well, first, some disclosures. We have nothing in particular to disclose. We were funded by the Dutch government mainly, and some very great small private funds, who didn't had any relationship with the food industry or whatsoever. We do have to say that we're vegan. We try to do our best, and being imperfect is actually rather an important factor also in our program. So imperfect vegans, that's what we are. And we're talking about today about rheumatoid arthritis and osteoarthritis. And perhaps some of you are rheumatologists or work a lot with people with arthritis, but perhaps also some of you don't. And there is quite a distinction between those two forms of arthritis. First, we have rheumatoid arthritis, which is, and I will refer to that as of now with RA. So rheumatoid arthritis, it's one of the three largest forms of rheumatic diseases. It's a chronic autoimmune disease in which joints are inflamed, but people also have other complaints like fatigue, pain, stiffness, loss of physical function. And it affects approximately 1% of the population in Western countries. Also in the UK, it's 1% of the population. And around 30 years ago, you still had people who had these grown joints, these affected joints. And today you really see much less of those problems, which is of course a major achievement. And we thank that to great medical treatment. So most people with RA can be treated with drugs, disease modifying anti-rheumatic drugs. And those drugs are quite heavy. So for example, methotrexate is mostly used, which is a chemotherapy, although in very small doses. But less than 20% really achieve remission. So it protects a lot of people from really misformed joints, but they really are not able to achieve this remission, so absence of complaints. And another side effect is that you feel nauseated or other side effects. And another problem with RA is that people with RA have twice the risk of cardiovascular disease when compared with the general population. Osteoarthritis at first sight is a really different disease. Most physicians will refer to it as your general wear and tear. Often it's being said that people with overweight suffer more from osteoarthritis due to the load, which is not really true, because people, for example, with obesity also have an increased risk of osteoarthritis in their hands, in which you don't suffer from that load. So something else is going on. But they do have twice the risk of metabolic syndrome when compared with the general population. A lot of people don't realize that osteoarthritis is really a really big chronic disease. Actually, it's way larger than, for example, diabetes type 2. And if you look, for example, in the UK, 1 in 10 people have osteoarthritis. And another very hurtful thing about osteoarthritis that you can actually, you can't do anything about it. People can take painkillers, or in the most extreme other side of the story, they can have a joint replacement surgery. So this is really a debilitating disease. It affects a lot of people, and the treatment options are very limited. And this chart is, this graph is made by the Dutch government. And as you can see here, we have at the moment around 1.6 million people with osteoarthritis. And this grows exponentially. This is the prediction for 2040 to 2.3 million people. So as of now, also in the Netherlands, we have around 10% of the people, and approximately 12 to 13% is to be expected in 2040. Then back to RA, because as I said, 30 years ago, we didn't have any medication. and a lot of damaged joints were the results of it. But what we did know was that if people stopped eating, so if they fasted, then a lot of RA complaints went away. So these researchers from Norway in the 80s thought, well, you can't fast forever. So what could we recommend to people after, for example, a week of fasting? And they thought perhaps a plant-based diet could be a good follow-up for a fasting of 7 days. So in this trial, they tried that, and what you see in the dotted line is the control group, and the other line is the intervention group. And what you actually see in this great trial, which was published in the Lancet in 1991, is that actually for almost all important outcomes for RA, fasting plus a plant-based diet could lower disease activity up to 1 year. This article, actually, there are very few rheumatologists who know this article, and it ended up in a drawer. Actually, we think because of the upcoming medications. What we also know about RA is that people who have a higher physical activity, so people who are more active, have a 35% lower risk of RA when compared with people who are not that active. So we know that physical activity has something to do with RA, and we also know that being active and doing exercise actually is recommended for people with RA. This is, of course, not so surprising. What did surprise me when I was preparing for this research was that people with extreme forms of stress, like, for example, the post-traumatic stress disorder, have an up to twice the risk of developing autoimmune diseases, and in particular also RA. So we know that stress is very much related to RA. And if you talk to rheumatologists, they also confirm this, that this is really an issue in people with RA. And if you take that all together, you could think of a multidisciplinary lifestyle program based on a plant-based diet, exercise, and stress management. And when we were preparing for this study, we ended up in a study done by Dean Ornish. He also started in the 1980s, and he studied the effect of such a program, such a multidisciplinary program, on people who had a stenosis in their coronary artery. So what you see in this graph is that people who joined this study, they had a 40% narrowing of the coronary artery. And after 5 years in a treatment group, so in the lifestyle program group, the stenosis was lessened a little bit, whereas in the control group, with people who also received regular treatment, the stenosis went worsened, actually. And this actually was the inspiration for us to do our Plans for Joint study. We work at Rheumade, and Rheumade is a rheumatology and rehabilitation center. And in the rehabilitation unit, we have a lot of people with osteoarthritis. So when we proposed this study to our board, the board said, well, that sounds really great for people with RA, but why don't you also take in people with osteoarthritis, because that is a very large group. And at first hand, I thought, oh no, another group, and that's a lot of work. And but actually, I'm very glad that we did it. So we digged into some earlier studies where more lifestyle components were combined for osteoarthritis. And actually, we ended up with very few studies. And actually, the only researcher who did some studies was Stephen Messier, a great researcher, who did great studies on combining diet and exercise in people with osteoarthritis. However, he is a very strong proponent of the load theory. He's convinced that osteoarthritis in knees and hips is caused by the load. And so he executed this program with a very low calorie diet and some exercise. But as you can see, the combination of diet and exercise that's here really reduces pain more than either one of them. So you see diet alone or exercise alone reduces pain, but if you combine them, it reduces pain more. So that was the idea behind the Plans for Joints study, but also the idea that in the base of both disease, you see this systemic chronic inflammation. And systemic chronic inflammation, of course, in RA, inflammation goes up very strongly. But for both diseases, you could say that a systemic low-grade inflammation is a kind of baseline. That's the reference point from where a disease worsens or where a risk of a disease increases. And systemic chronic inflammation is a kind of, because inflammation, of course, is a good reaction of our immune system. But if immune cells are active, like cytokines and white blood cells are also active without an urgent problem, then it can also damage our body. And systemic chronic inflammation is promoted by a bad lifestyle, so obesity, physical activity, diet, isolation, chronic stress, and disturbed sleep. And of course, it's all bi-directional. So all these lifestyle factors also influence one another. And when systemic chronic inflammation starts, you most often see it first in the development of metabolic syndrome. And metabolic syndrome is a combination of overweight, high cholesterol, high blood pressure, high blood sugars. You see type 2 diabetes or pre-diabetes, and NAFLD, which is non-alcoholic fatty liver disease. And we'll come to that fatty liver in our results as well. And you see those other diseases developing. And if you look at those diseases, then you can also see that if people develop, for example, an autoimmune disease, then quite quickly they also develop other diseases, like, for example, cardiovascular disease. So this idea of systemic chronic inflammation, the fact that it is promoted by all these lifestyle factors, the good experience and great results done by, given by the studies by Dean Ornish, that inspired us to develop the Plans for Joints program. And the Plans for Joints program, we wanted to do this program to lower disease activity in rheumatoid arthritis and to improve pain, stiffness, and function for osteoarthritis. And if we look at rheumatoid arthritis, then we look at the DAS28, and the DAS28, that is the disease activity score for 28 joints, and that is the most widely used indicator for disease activity in rheumatoid arthritis. And it is also the outcome that is used by rheumatologists to manage the disease. Whereas the WOMAC, which is a questionnaire for pain, stiffness, and function, is the most widely used outcome to measure effectiveness of intervention in osteoarthritis. So what is this Plans for Joints program? Well, the Plans for Joints program is about a plant-based, healthy, whole foods diet. But of course, it's only sustainable if it's tasty, because if it's not tasty, then people will not do it. They will not adhere. Plans for Joints, however, is also about sitting less and moving more, physical activity as a core of our program. And of course, also sleep, because people who sleep have bad sleep, who sleep too short or have a low quality of sleep, they eat more unhealthily and also have higher inflammation. And in the end, also about relaxing more. The design of our study was that we had 3 randomized controlled trials. We discussed only 2, rheumatoid arthritis and osteoarthritis. The third one was a small pilot study on people with an increased risk of rheumatoid arthritis. And we had a randomized controlled trial in which we put people in the control group. They were getting usual care. They were put on a waiting list control group, so as to, of course, make it also attractive for them to join this study. And after 4 months in this study in the control group, they were able to follow the program as well. And the program consisted of 4 months, 10 meetings in groups of 6 to 12 people. And after 4 months, the randomized controlled trial was concluded, and it was followed up by a 2-year extension study. We included people with rheumatoid arthritis and osteoarthritis. I will not go into the details too much. And we had some exclusion criteria. For example, the plan already having a vegan diet, of course, because then the difference is not large enough. Underweight, because people lose some weight, smoking, pregnancy, and low e-health competencies, because we used some apps. And then the plans for joints measurements were a lot. We had all kinds of anthropometric measurements like length, weight. We also did DEXA scans to study body composition. We took blood, saliva, feces. We are actually now running a microbiome study on it. And of course, all kinds of questionnaires. And actually, the funny thing is that we had a very low dropout, but the people who dropped out because of the many measurements. People were in the end a little bit sick and tired of all the measurements and all the visits they have to do. So that is a little bit of an introduction to the Plans for Joints program. And I will now hand over to Carlijn to share with you the results of the Plans for Joints program. So Carlijn, you can now.
Great. Hi, everyone. Thank you so much, Wendy. I'm immediately going to share my screen and pick up where you left off. I believe you can see the screen now. So today I'm going to be talking about the results of our Plans for Joints study. And I'm going to start with the rheumatoid arthritis group. So we had 77 participants who were included in our rheumatoid arthritis study. And of these participants, 40 were included in the intervention group and 37 in our control group. On average, participants had an age of 55. The majority was female, and we obviously also often see that more females have rheumatoid arthritis, but we attracted mainly females in our study, so the average females is higher than those with rheumatoid arthritis. Additionally, we, on average, participants had a DUS-28 score at the start of this study of 3.8, and this is indicative of a moderate disease activity. Now, when we look at the effects of our study on the DUS-28 score of rheumatoid arthritis, on the red line here, that's the Plans for Joints group. So those are the participants who received the intervention, and the blue line indicates the control group. And what we found is that after 4 months, a significant decrease in the DUS-28 score, so the disease activity as compared to the control group. Now, there's 4 components of the DUS-28 score. We have the number of swollen joints, the number of painful joints. We have a blood marker indicating inflammation. And we also ask participants on a scale from 0 to 10, how much impact their disease had on them in the past 48 hours. Now, as Wendy also indicated, we did a lot of other tests. So when we look at some of those secondary outcomes, we found that on average, participants showed a decrease in weight, body mass index, and waist circumference at the end of the 4-month period as compared to the control group. Participants also showed improvements in blood sugar levels indicated by the HbA1c, which is an indication of blood sugar levels over the last 3 months. And we also found improvements in LDL cholesterol as compared to the control group. Now I'm going to go on to the results of the osteoarthritis trial. What we found is, well, first of all, we had 64 participants who joined our trial. These participants on average were slightly older than the rheumatoid arthritis group with an average age of 63. In this group, also the majority was female, but we did have more males in this patient group. And as you can see that the body mass index of this group was also higher. And as Wendy indicated, that's on purpose, and that's because these participants also have metabolic syndrome. Now, when we look at the WOMAC score at baseline in these participants, this was, they had an average WOMAC of about 39, which indicates a moderate to severe form of osteoarthritis. Now, in this graph, you can see the effects of the Plans for Joints trial on the WOMAC score. And as Wendy indicated, the WOMAC score is a questionnaire that addresses pain, stiffness, and physical function. Now, we saw at the end of the 4 months, as seen by the red line, that the Plans for Joints group showed a significant improvement in the WOMAC score as compared to the control group. And also in this group, we look at the secondary outcomes. So here we saw that at the end of the 4-month period that there were improvements in inflammation as well as the body composition. So in this group, we found that at the end of the 4 months, participants on average had a weight loss of 5 kilos. And also, for example, improvements in body mass index and waist circumference. We also saw that improvements in blood sugar levels, for example, also the HbA1c, but also the fasting blood glucose, and also the LDL cholesterol. Within our osteoarthritis group, we asked a subgroup of people to also join our MRI study, and 32 of our osteoarthritis participants joined our study. And what we were interested in this study is looking at the body fat distribution throughout the body. So in this figure here, in figure A, you see a transverse section of someone's body. So this is kind of the front side of the body, and this is their back. And here in this area, you can see their liver. This little white box indicates the portion of their liver that we tested. And what we actually looked at within this portion is the amount of water and the amount of fat. And we measured this in a graph like this. So here you can see a peak showing the water, and here this peak shows the fat. And by looking at those peaks, we were able to calculate the percentage of fat within the liver. And when we look at our example patient in figure A, we found that this participant had a 31% fat in their liver. And to put that into context, we diagnosed non-alcoholic fatty liver disease at 5%. So this is a very high amount. And what we saw is at the end of the intervention that this particular participant had a decreased fat in their liver up to 7%. And what's interesting is that you can actually also see that the liver changes in color. At first it was a bit more gray, and then it becomes more black. And we can see that back in this figure whereby the green line indicates the baseline. So here the fat peak was a lot higher. And after the 16 weeks, the fat peak is a lot smaller, indicating they lost a lot of fat. And to compare in the control group, we found that actually in this patient, the fat stayed the same and even increased. Now, of course, these are only 2 people, so it's important to look at the whole group. And what we found is that at the end of the 4-month intervention, there was a significant improvement in the liver fat percentage as compared to at the start of the study and compared to at the end of the study, the control group. The participants in the intervention group started at 7% fat and dropped down to 2%. Now, when you do a trial like this, it's always interesting to see what people are actually doing, because you may give them all these advice, but the question is whether they're actually going to follow your advice. So obviously we wanted to check up on them, and we did that first of all with food diaries to assess what they were actually eating. And here you can see their energy intake. The red bars indicate the intervention group and the blue bars indicate the control group. And what we saw is that participants didn't change their caloric intake that much. So there was a slight decrease in calorie intake in the intervention group, but overall it didn't change that much. And this also is what we advise patients to do because they were asked to eat ad libitum, also known as, as much as they needed to until they were satisfied. When we're looking at plant-based diets, there's two nutrients that we find really important, and one of them is fiber, and that's because whole food plant-based foods have a lot of fiber. So in order to check how adherent these participants are to our diet, fiber was one of the important nutrients we looked at. So again, here, the red bars indicate the intervention group and the blue bars indicate the control group. And what we saw here is that at the start of the study, both the control and intervention groups were under the daily recommended intake of fiber. And in the Netherlands, that's 14 grams per 1,000 kilocalories. What we found is that at the end of the 4 months that the participants in the Plants for Joint study, they increased their fiber intake till 20 grams per 1,000 kilocalories, which is a really nice increase. And what's also good to know here is that these are the results for both the rheumatoid arthritis and osteoarthritis groups combined. That's why you see here on the right-hand side that the numbers are a bit higher. Now, the second nutrient that we're really interested in is saturated fat, and that's because animal products are naturally a lot higher in saturated fat. So you would expect people that are adherent to a whole food plant-based diet that their saturated fat intake would also decrease. So what we saw is that at the start of the study, both the intervention and the control groups had a saturated fat intake of about 13 energy percent. And our Dutch dietary guidelines aim to get people to eat under 10 energy percent. What we saw at the end of the 4-month intervention is that the participants reduced their intake till 9 energy percent, thereby allowing them to adhere to the recommended dietary intake. Another important thing, which everyone's always worried about when it comes to plant-based diets, is protein intake. So we also, of course, measured that. And the recommended intake for protein is 0.8 grams per kilograms of body weight. And what we saw is at the start of the study, both the groups adhered to this dietary recommendation. But what we did see is that within the Plants for Joint intervention group, that they dropped down till 0.7 grams per kilograms of body weight. And although we did advise the participants to eat enough protein, this is definitely something we're going to take with us into the future, that we are going to re-emphasize this point because it is really important that people get enough protein. And if you give them the right recommendations, it doesn't have to be something that has to be very difficult, but it is an attention point for the future. Now, another thing that I want to be talking about today is the process evaluation that we did. And I showed you a lot of quantitative data, so a lot of numbers, but we were also interested in the qualitative data, so more of the experiences that the participants had. And also, for example, which factors of the program were useful and their satisfaction of the various parts of the program. So what we did is we asked all our participants to take part in an online questionnaire, and we also invited everyone that took part in the study to join focus groups. And in these focus groups, we did 5 focus groups with about 6 to 8 participants, and we really focused on their experiences and feasibility of the program. And we were interested in what components of the program are most important and were most useful for people to make their transition to a more healthy lifestyle. Additionally, we interviewed all the coaches, so think of the dietitians, but also occupational therapists and the sport coaches who really gave this intervention to all the participants. And there we asked them to evaluate the program and also assess the fidelity. And the fidelity is the extent to which they performed the program as they were expected to or instructed to do so. Now, what we learned from our evaluation is that, first of all, we had a very motivated patient population, and that's really important, and that is what we selected people for. We wanted people to really want to make lifestyle changes, because otherwise, it is something that someone has to want to do themselves. And the reasons why people were motivated to join was, first of all, because they wanted to reduce their symptoms without more medication. They wanted to prevent their symptoms from worsening. And they also really believed that lifestyle changes could influence their symptoms. Other participants also indicated that they wanted to be more in control of their disease and health. And also some wanted to join the program because, for example, they had a lot of side effects of their medication. So they wanted to see if they could, for example, reduce their medication and thus also have less side effects. Another factor we learned was really important was social support. So our program was given in a group setting. So we had 10 group meetings with about 6 to 12 participants in each meeting throughout that 4-month program. And some participants indicated that that group dynamic was one of the most important parts to make their lifestyle change. And someone even indicated it felt like an AA meeting. What also was important was not only the social support within the program, but also outside of it. So for example, if a partner at home helps with the cooking or goes on a walk with them, or if children also want to join in with eating the same meals together, that makes it a lot easier for people and also makes it better for people to maintain these lifestyle changes in the long run. And what we also learned is that, for example, some of the partners of our participants also indicated that they lost a lot of weight and they also improved their health. So you also see that the effects trickled down to their environment. We also had various tools and activities within our study. So we gave all our participants a Fitbit, and this Fitbit gave participants insight into, for example, how much they were moving, so how many steps they were making per day, allowing them to set goals. For example, if someone wanted to walk 10,000 steps a day and they hadn't met their goal yet by the end of the evening, that would motivate them to go outside for a walk. It also looked at it wasn't a perfect measurement, but it looked at like the amount of sleep a person had, just to give them insight into, hey, how am I actually doing? And where are things that I can change? We also asked participants to fill in a food diary. And for this, we used the 8-meter, which is a Dutch validated food diary. And this 8-meter was seen as very insightful and useful because it really showed patients where they were coming from and where the improvement points were for them, and also where there were attention points, for example, if someone's getting enough iron or protein in their diet. This was also useful for the coaches because the coaches could assess the dietary intake and give personalized advice. Another activity within our program was individualized coaching. So participants, when needed, could contact one of the dietitians for one-on-one counseling, but also, for example, if they were struggling more with the stress component or the sleep component, they could ask for personalized advice when it came to those lifestyle factors. We also learned that the team, so really the coaches were a success factor, and the participants let us know that that was because the coaches all were engaged and enthusiastic, and the participants really felt that they were taken seriously. And someone also said, like, gee, finally someone is actually working on my health with me. And also what we heard that was beneficial is that most of the team actually also eats plant-based. And why this was seen as beneficial is that the advice given by the coaches also felt authentic and the tips came from someone's own experience. Well, overall, we assessed the overall satisfaction of the program. And what we learned is that in general, participants were very satisfied with the program. They felt that the program was very complete, and they also liked that it covered all the lifestyle components. We asked participants on a scale of 1 to 10 how likely they were to recommend the program to someone else that they knew with their diagnosis, and they scored it a 9.2 out of 10. Of course, there were many improvement points which we're taking with us into the future, and I'm going to highlight some of those now. One of them is repetition, so repetition of information, but also repetition of activities. For example, at the start of the study, we started our group sessions with a cooking workshop, and this was really highly appraised. And also we heard from participants that they would have liked to have a cooking workshop a bit later in the group sessions as well, just because when you're a bit farther along, you might have different questions and you also might want to advance your cooking skills. We also will be adding more structuralized individual guidance into the program and therefore adding a more personalized approach. What we did now within the program is that when necessary, participants were able to contact, for example, a dietitian for extra advice. But in the future, we really want to structurally integrate that component into the program. Also, as I said earlier, insight into how many steps someone's taking or what someone's eating is very insightful and motivating. But what we also learn is that it's important that people get insight into their progression. So for example, having an overview of their weight loss journey or an overview of their blood labs, that can be very motivational, because some people might not feel that their pain is being reduced yet or at all throughout their trajectory, but their blood pressure might be improving or their LDL cholesterol is decreasing. And if you don't give participants that feedback and really visualize to them from, hey, okay, your pain might not be decreased right now, but you really are making progress and you really are improving your health for the long term, a participant might give up hope. So giving that insight into one's progression can really help keep someone motivated to keep going sustainably in the long run. An also interesting component of our program is that due to Corona, unfortunately, our program initially was completely live, but we had to offer the program online as well. So a third of our participants followed the program live, a third of them followed it online, and a third had a hybrid form of both live and online. And what we learned is that although the online form increases feasibility because people can stay at home and they don't have to travel, but we did learn is that being together live one-on-one really makes it so that group discussions are easier, and also it makes it easier for that group dynamic to form, which is what we learned is really essential for that social support. So having a combination of online and live is probably the most ideal form in the future. Well, with that, I want to conclude. So what we found is that our plans for joint study resulted in improvements of disease activity in participants with rheumatoid arthritis, and also improved pain, stiffness, and physical function in people with osteoarthritis. We also saw various improvements in metabolic outcomes, including also improvements in liver fat, which also indicates that the general health of these participants increased, and a program like this is potentially also relevant for other chronic diseases. Of course, our program has both strengths and limitations. So first of all, strengths is that we were able to show a clinically relevant effect. Also, we learned that our program is highly appraised and it can potentially also be relevant for other chronic diseases. But limitations of our study is that we had no objective markers for adherence. So all the data on the food intake and how much, for example, someone exercised per week was self-reported. And also, although we had a control group, this control group just followed usual care, so they didn't receive any other attention. And there also wasn't a placebo, which can also be seen as a limitation. Overall, some take-home messages: if you have a patient that comes to you with rheumatoid arthritis or another chronic disease, and they ask, hey, can I do something about it myself? Yes, yes, they can do something about themselves. And I think as a health professional, your job is really to identify, hey, where is room to use lifestyle within your clinic, and also motivate people and share the evidence with them that various approaches can have effects on their health. In general, dietary guidelines are a great place to start, but every step to a more plant-based diet comes with health advantages. So stop eating processed meats, avoid red meats where possible, reduce dairy intake to also reduce the saturated fat intake, and really focus on whole grains, more legumes, and more fruits and more vegetables. And as we also advise with our patients, it's also good to supplement with vitamin B12, D, and algae oil for the essential omega-3 fatty acids, especially in people that are following a predominantly plant-based diet. So again, we will be in London in September, and we have the one-year results after our Plan for Joints trial that we're really eager to share with you. So we hope to see you all live there. And lastly, I want to thank everyone that contributed to this study, and I'm very excited to go into discussion and hear if there's any questions.
That was absolutely fantastic. And as I said before, when I had a sneak preview of the slides, that, you know, it was the most beautiful presentation and it really blew me away, and you both presented amazingly. So thank you, a fantastic study. And it's great to see such a diverse audience as well this evening. We have people joining from Lithuania, the Netherlands, Mexico, South Africa, the UK. So yeah, really thank you so much for joining, and do pop your questions in the Q&A box. So I wanted to, dive into kind of what is a hot topic. I think there've been some new dietary guidelines released this week as well, promoting the consumption of fish, and that is what most rheumatologists sort of advocate for or advise. What are your views on that? And would also love to know your thoughts on omega-3 supplements besides obvious sources of ALA such as black seed, chia, walnut, hemp in a plant-based diet. But yeah, would love to know your thoughts on those two things.
Yeah, well, actually, fish indeed is considered to be a healthy food, especially for people with rheumatoid arthritis, because there is some evidence that it is that it lowers disease activity actually. However, most of the heavy metals and PCBs that we get inside our body is actually thanks to a very small percentage of our food, which is fish. So because of that, we are a little bit worried that people will get too many heavy metals and other toxins in their body. So from that point of view, we recommend people to not eat fish, and if they do, to eat only small fish. People who don't eat fish are actively recommended by us to take algae oil supplements to get the long chain omega-3 fatty acids, especially for this patient group, both of them, since they have a little bit of increased inflammation. That's one reason. And of course, these people are also 50 plus, so most of them. So also from that point of view, I think that it is to be considered, that it is to be recommended to supplement with algae oils. We take them ourselves as well. So that's for the fish. Yeah.
Wonderful, thank you. And how can we get rheumatologists on board? What is your advice? That seems like an area where it can be a real struggle. So what are your tips? And yeah, you mentioned in the end kind of integrating things as much as possible into your lifestyle practice and into your health practice, and integrating lifestyle and nutrition advice. But do you have any tips on how we can reach, rheumatologists, particularly the kind of next generation?
Well, I think, and we saw that within our own hospital, and Wendy really struggled with that in the beginning because a lot of rheumatologists were very skeptical and it's quite aggressive when the study was started. And what we learned is just keep going. So for example, now that we have these results, one of the most skeptical rheumatologists, he came to me last weekend and he was like, oh, I have my whole vegetable garden now and I'm eating plant-based schnitzels. And they gradually also see that if the evidence is there, and they also notice that, hey, my patients are getting better, that it definitely has effect. So I think on the one hand, creating awareness that, hey, there is evidence, and showing, and that can also just be that if one of their patients shows good effects, that, hey, it is worth it to look into this. And I think also making it really easy for these busy health professionals to integrate something into their clinic. And the advice I always give them is, first of all, there's a couple steps you have to take, but you don't have to do everything. So try to just see, hey, where is this patient at? Is lifestyle applicable for a patient right now? If they're if their rheumatoid arthritis is very active, hey, this might not be the right time to address something like this. But when an opening comes, take advantage of that. So it's really that screening of a participant. And that also is, for example, if they have a high blood pressure or cholesterol, those are also cardiovascular risk factors, and that risk is increased in rheumatoid arthritis. So those are all openings to discuss lifestyle components. Then it's also giving information, motivating, and then referring your patient to your network. So use your network, find those people in your network that can give the dietary advice. So the dietitians, the physical therapists, the sport coaches. You don't have to do it all yourself. And our boss always says that, hey, within a couple minutes, he's already gotten a patient enthusiastic, and you can really get a lot done with a short amount of time.
Yeah, and also, I said at the beginning, we're imperfect vegans, and imperfection is actually the magic word in our program, because as of the beginning, we motivated our patients to not go for perfection, to do whatever they can do, and to not be too heavy on making mistakes or indulging in something they really like. If you take that into account as of the start of of such a, let's say, change in lifestyle, then the acceptance is way higher, adherence is better. And if you use that same kind of, let's say, mild communication, but let's say strong on the evidence, but mild communication, and also openness to the skepticism, then you stay, let's say, in talking terms. And as Carlijn said, they were quite aggressive to me in first hand, but just come back and try it again and keep on going.
Oh, fantastic advice. So unsurprisingly, one of the questions that's come up repeatedly in the from the audience is around protein and whether 0.8 grams per kilogram of protein is enough. You know, there's been various kind of thoughts on whether plant-based diets should slightly skew upwards of that, particularly if you have an active lifestyle, maybe 1 gram per kilo, and you know, more if you're very active. Love to know your thoughts on that and what you kind of found during the course of the study as well.
Yeah, well,
Wendy, do you want to take it away?
The regular protein recommendation here in the Netherlands is 0.83 grams per kilogram of body weight. And if you, I already saw a Dutch one responding that indeed for vegan diets, we recommend 30% more. So that's around 1 gram per kilogram body weight. It is very difficult if you have an RCT. You want people to adhere as of day one. So you can't say gradually step from a omnivorous diet to a plant-based diet. For protein intake, that's quite a challenge, because if you want people to adopt a whole food plant-based diet, they have to eat quite some legumes, so beans and lentils and stuff. And the gut has to need some time to adapt to that. So in our program, we saw that people indeed had some difficulties in the beginning to really get to the 0.8 grams, and they needed time to do that. However, we also saw a little bit of a small loss in muscle mass. So I do, and I know of other studies where they supplemented with protein. So it is possible to lose weight because they all lost some weight. It is possible to lose weight, and with the good amount of first exercise, because without exercise, protein will not even be, let's say, absorbed well, and the right amount of protein, I think it could be possible to lose fat mass without losing muscle mass, but not when you go from 0 to 100% in one day without supplementation.
Fantastic, really helpful. One quick question was, were the patients continuing to take their medication during the course of the study?
So the patients we included patients if they had stable medication for at least 3 months beforehand, specifically for rheumatoid arthritis, because that has a large impact on their disease activity. And within the randomized controlled trial period, we aimed them, or we asked them to really keep their medication stable. So that was, I think there was a couple deviations, but in general, the medication stayed the same within the 4 months.
Fantastic. And a few people wanted to know a little bit more about the plant-based element of the program in more detail. What sorts of meals were eaten, and what advice did you give to people who sort of had mobility issues, or were really struggling with symptoms of RA or OA, and they were just struggling to kind of prepare the healthy meals? What tips did you give those people?
Yeah, well, what we did was we made a great recipe book and weekly menus. We calculated all the recommended daily allowances, so they had really great great menus. And but we also gave them information on how to do it themselves, what kind of guidelines they could follow. So you saw people who just said, okay, I can cook well. I will just replace this with that and follow these guidelines. And there were some people who followed these weekly menus very thoroughly. In the weekly menus, the basic idea was 3 meals a day. So no snacks, 3 meals a day, with and the basic idea was the dietary guidelines in the Netherlands, but then translated into a whole food plant-based diet. So I saw also questions on oils and stuff like that. So as for the recommendations, it was, let's say, around 50% carbs. It was around 25% fats, and a lot of fiber, and of course also protein, and protein 1 gram per kilogram as recommended. However, no specific, it was not very different. I think if you follow the Harvard Healthy Eating Plate or your local dietary guidelines, and you just translate them to a whole food plant-based diet, then you will end up with anything that we would recommend. And I also, in that line, I also saw a question about our recommendations regarding oils. What we, of course, we recommended to lower saturated fatty acids like coconut oil and stuff like that. We recommended olive oil as, let's say, first choice oil to use when cooking and baking and stuff like that, to and just to lower additional refined oils, as the idea was that you make your diet as unprocessed as possible.
I think that's great advice. And a few questions about kind of patients who have RA sometimes do have digestive issues, and kind of adjusting to that higher fiber intake. Obviously, you know, here in the UK, only 1 in 10 adults gets the fiber recommendation. I assume it's not dissimilar in the Netherlands. So how did you kind of build up that tolerance to fiber, or kind of things like beans and lentils, which often are difficult to digest if you haven't been eating them before?
Yeah, no, that's definitely a difficult point. And as Wendy said, we made them go from 0 to 100 in 1 day, essentially, or as soon as possible. So we didn't have an adjustment period. And for some people, this gave some symptoms at the beginning, and some, you know, came to us like, hey, I'm intolerant to this. What can I do? And what we learned from that is that in the future, build it up slowly. So use cooked vegetables, and there's certain legumes that people might react more to. So for example, lentils might be gentler at the beginning, and then build it up. And also what we've learned throughout the process is that, for example, fermented foods are also a really great starting point, because they also have a lot of probiotics, so bacteria in them, and partially digested fibers. So ramp up the fermented foods and slowly integrate the fiber intake. And that's something that we're going to be using in the future, when we're not in such a randomized controlled trial setting.
Fantastic.
Yeah,
and if people want, oh, sorry.
In addition to that, and the question on people with RA who have very specific digestive issues, we do see them. Neil Barnard actually also did a study with RA patients, and he had this kind of elimination and reintroduction diet, as to take into account those, let's say, sensitivities. We chose not to do that, also because if people have issues, we just advise them to lower for example, if they had issues with chickpeas, we just advise them to lower the intake of chickpeas, but not to stop it, as our idea is that it has to do with an imbalance, a dysbiosis in their microbiome. And if you keep on taking, although to a lesser extent, a certain food, then perhaps you can, let's say, improve your gut microbiome a little bit, and people, can improve their digestibility a bit.
Fantastic. I'm just going to launch a quick poll. There's so many questions and I wish we could just, pick your brain on everything, but I want to kind of wrap up with a final question, which is, based on everything you know, do you recommend plant-based diets for other autoimmune conditions, and why? Because obviously there's just a few that you've kind of covered, but there's such a huge spectrum out there, and patients are often really lost because there's so much conflicting dietary advice on the internet when it comes to autoimmune. And I'd love to know both of your thoughts on this.
Yeah. Well, first of all, I wanted, because I saw some questions, where can I start and stuff like that. I will share in the chat 2 websites, one in Dutch and one in English. And people, I really recommend people to subscribe to the newsletter, because we are definitely planning to implement this. And if you subscribe to the newsletter, we will update you as soon as possible on the latest news on that. So I will share that. And I definitely recommend people with autoimmune disease to try this, because we think that a lot of diseases actually begin with inflammation, this low-grade inflammation. And I think there's more than enough evidence to suggest that a whole food plant-based diet and exercise and stress management and better sleep together really can contribute to lower inflammation. So that's, I hope, the way to go in research and healthcare.
Love that.
Yeah, and just to add on to that, there's a lot of emerging evidence now also with the microbiome and the influence of the gut bacteria on also the break intolerance with autoimmune diseases. And we know that adding fiber and unprocessed foods and reducing the animal dietary intake, really improves and can change the microbiome. And those are all steps, which help reduce inflammation as well. And so we're really hoping, or very excited to see what's coming out of our microbiome study. But that's also one of the factors that's really important, and that's why we advise a more whole food plant-based diet as well.
Fantastic. Well, this has been really illuminating and fascinating to hear more about the study. I'm very excited for VegMed to kind of pick your brains in person and learn a bit more as well about the study and the long-term impact as well. So thank you everyone for joining. Everyone who's attended, you'll receive a copy of the slides in a few days, and again, recordings are open to PBHP members. And do check out our website, plantbasedhealthprofessionals.com. Do check out the websites that Wendy has popped in the chat, because these look really, really fantastic and a great way to stay up to date with what the program is doing. And just some lovely comments from everyone as well. So thank you again, and have a lovely evening.
Thank you.
Thank you.
Good night.